Hello everyone, let me introduce myself. Myself, Vishwarupa Bhoi, a final year BPT student. Today, we are going to read about skeletal tuberculosis, a orthopedic chapter you all know. It's my favorite chapter and I will try to do your favorite also by explaining in details. Okay then, let's start the class. Let's start skeletal tuberculosis. Tuberculosis is an infectious disease, right? Primarily affect the lungs, which is the primary site, and then gradually it infects the other body tissues like bones, joint, and brain. In bones, that is known as skeletal tuberculosis, and in brain, you all know, right? That is TB meningitis. After lungs and lymph nodes, bones and joints are the common site of infection in TB. Causative organism, Mycobacterium tuberculosis. Skeletal tuberculosis is always secondary and it constitutes about 1 to 4% of total number of cases of TB. The spine is the most common site of skeletal TB and it's known as port spine. About 50% of cases next in order to the frequency of hip, knee, shoulder and elbow. Tubercular osteomyelitis more commonly affect the end of the long bones. As we know, at the end of the long bones, there are epiphyseal plate which are highly vascular in nature. Also, we all know that is as growth plate. Moving towards the causes and precipitating factors, Mycobacterium tuberculosis, common causative organism, routes of infection by hematogenous spread, that is Batson plexus in TB spine, and also can be through the lymphatic spread or direct extension from a neighboring focus. Precipitating factors like anemia, debility, infection to increase more. Debility is weakness. Any trauma causes vascular stasis and intraosseous hemorrhage localize the problem to the bone, precipitate the infection. Moving towards the pathophysiology, TB infection of the bone and synovial tissue produce similar response as it produced in the lungs, that is chronic granulomatous inflammation and caseation necrosis. Caseation necrosis is cheese-like appearance of the tissue which are dead cells. The response may be proliferative or exudative or both. Proliferative is more common by granulomatous inflammation with a lot of fibrosis, and in exudative, particularly seen in immunodeficient individuals, elderly people and leukemia patients. It is extensive caseation of necrosis without much cellular reaction, that is extensive pore formation termed as non-reactive cases. Let's clarify the pathophysiology in details. First of all, after involvement of the joint, there will be starts of low-grade synovitis. Synovitis, no, that is inflammation of the synovium fluid. Thickening of the synovial membrane start destroying the cartilage from periphery. The inflamed synovium at the periphery of cartilage is called penos. Eventually, whole of articular cartilage is destroyed, joint get distended, and the joint capsule and ligament become lax. After that, the subluxation of joint occurs. After that, there will be discharging sinuses are found in the superficial layer. Healing caused by the complete loss of joint movement, that is fibrosis of joint, called is fibrous ankylosis. Destruction of articular cartilage and occurred at joint space is totally lost and is traversed by bony trabecula between the bones forming the joint called bony ankylosis. Look at the structure. It is fibrous ankylosis. It is bony ankylosis. It is the totally fusion of the joint. There is no chances of any movement. Surgery is must. Okay. At the early stage, there will be only synovitis, joint involvement and synovitis. After that, there will be the destruction of the articular cartilage in the joint. After that, look at the C image. There will be complete destruction of the articular cartilage, and after that, at the healing phase, there will be the D, that is the bony ankylosis. Okay. Bony ankylosis form due to the complete loss of the joint space. What's the clinical features? Clinical features depend upon the site of infection. Patient usually complains of pain, swelling, deformity, inability and wasting of limb muscles. Constitutional symptoms present in approximately 20% of cases, that is fever, weakness, loss of appetite and weight, night sweats, anemia, tachycardia, evening rise of temperature. Investigation. We go through the radiological investigation, that is X-ray in AP view and lateral view. Compare it with identical X-ray of the opposite limb or repeated X-ray. Finding includes TB osteomyelitis. It presents a well-defined area of bone destruction and minimal reactive new bone formation. This is the normal. This is the TB osteomyelitis source of the bone. Look at this. Look at this. This is the TB osteomyelitis. After that, there will be TB arthritis, loss of joint space in the joint, erosion of the articular surface. After that, we can see the chest X-ray. As I already said, TB is primarily affect the lungs. That's why we can check the chest X-ray to see the tubercular lesion in the lungs. Other investigations include blood examination and increase in ESR rate, Mantox test, serum ELISA, enzyme-linked immunosorbent assay for detecting the antimycobacterium antibodies. Synovium fluid aspiration. It will look as yellow color and low viscosity and more than 3.5 ml if the infection is there. Aspiration of cold abscess and examination, histopathological examination. I would like to explain Mantox test. Small amount of tuberculin injected just under the skin of forearm. A reaction, that is red area found at the injection site, is measured after 48 to 78 hours of indicating potential exposure to TB. Class, we will read about the treatment plan on the skeletal tuberculosis. If there is any doubt in today's class, write it in comment section. I will try to clear it. If you find it is informative, subscribe my YouTube channel. Like, comment and share with your friends.